first of all, welcome everyone. I'm really excited to have this important conversation today, and I'm delighted to welcome my colleagues Bray Patrick Lake and Christine Manta, who were the co-creators of this really important framework, developing digital measures of health that matter to patients. This has been something that increasingly is on our mind at Dime, and I'm delighted to be able to have Christine and Bray walk us through the framework today and talk about how we can start implementing that today in our work. Before I go ahead and ask our experts for today to introduce themselves, we'll run through just a bit of housekeeping for folks who may not have joined a journal club before. So I always like to warn folks, we are recording today's session. So full disclosure, what that does mean is that the recording and the slides will be available later. We'll post them later today to the website in case you have colleagues who couldn't join today but would find it valuable. The Journal Club, we're going to have some insights from Christine and from Bray from sort of behind the scenes as they put the paper together, and have them sort of highlight and speak to key themes and elements of the framework. But we'll spend most of our time today in discussion. There's a couple of ways for you to participate. I will monitor both the chat and the Q&A function, so feel free to use those to type your questions in. If you prefer to ask your questions live to Bray and to Christine, just raise your hand and I'll unmute you and you can dive in and join us in the conversation. So with that, again, welcome everyone, and Christine and Bray, I'll hand over to you.
Great. Thanks so much. So Bray Patrick Lake, I'm the Director of Strategic Partnerships at Evidation Health. My background is largely in patient engagement. I founded and led a patient advocacy organization. I've been involved for the last decade in developing frameworks that engage patients in clinical trial and research design. Christine?
And I'm Christine. I lead the research team at Electrolabs, where we're building a platform for evaluation and deployment of connected sensor technologies in research and clinical care. My background is in health services research. I worked in academic institutions and hospital systems for a number of years. And then prior to joining Electra, I was at Citi developing their database of feasibility studies, evaluating mobile tech. I'm also trained as a registered dietitian and worked clinically. And keeping patients, the focus of these conversations has always been important for me in that space. So I was excited to work on this paper with Bray.
Thanks. Well, let's dive in. So this slide has been adapted from Evidation Health, and it's become known as the Iceberg Slide. And so I think it gives us a really terrific picture of kind of where we've been in the past, which is measuring patients' lived experience and health very episodically and traditionally in the clinic, which can present a variety of challenges related to performance and just variables that can't be controlled, even if somebody has their blood pressure measured and they've just walked a long distance from a parking lot, per se. And so we've known as patients that there's been a better way to measure health. And now through remote monitoring and connected sensors, the possibilities are really endless. And so we're generating thousands of data points every day about our biological processes and about how we feel and function. And so while this is a tremendous opportunity, it also means that we should proceed with caution, because we have an opportunity before us, but also a bit of a challenge where sometimes we see high signal and it's very tempting to measure something that we see, but that doesn't necessarily mean that it's actually important to patients or clinicians. And so if you go to the next slide, Jen, it's very important that we work hand in hand with the patient community continuously throughout the process of understanding what's most important to them. So it's incredibly just imperative to where we are at the state of this work that we make sure that as we're developing these novel measures, that we measure something that from the patient perspective is important in detecting a change that actually matters to the patients. So we'll just go ahead and just set this up that you need to engage early and often, and also make sure that we're engaging continuously throughout this process. And that's what really led us to pull together this framework that draws upon some of the publications and frameworks that were existing, but we wanted to make them specific to digital measures, and ensuring what matters to patients is front and center all the time. Next slide, please.
So this is the framework that we developed in the paper. This is the main key figure in that paper. So we'll talk about it at a high level here. And then the sequential slides break down each of these decision points of how you move from a meaningful aspect of health to a concept of interest, to an outcome, to an endpoint, and ensuring that there's patient input that's happening at each of those steps. Because at each level, as you can see, we included multiple little icons in each rectangle, because there's multiple options you can select there. And then so how do you know which one you should move forward with? And the answer is patient engagement and hearing what they have to say. So if we go to the next slide, Jen, I think it'll make more sense to talk about them. Yeah. So we start with the meaningful aspect of health. And the meaningful aspect of health is an element of a disease that the patient wants to either prevent, see improvement in, or doesn't want to get worse. So I often think of the meaningful aspect of health as being in the patient's own words, and then you can translate that into maybe a summary statement. So your patient may tell you, I want to be able to carry my groceries, or I want to be able to play with my kids without pain. So that might look like the ability to perform ambulatory activities. And then you think, okay, how can I practically measure that in my clinical trial or in the clinical care space? So that's how you move to the concept of interest. And then that is the element that can be practically measured. And that's still broad, right? Things like walking capacity, lower extremity balance, lower extremity strength still need to be broken down. But there are a couple different options there depending on what your patient population is telling you. And I guess move to the next slide. Oh, great. You move to the next slide. I did not move to the next slide. Thanks, Jen. So then once you've decided on your concept of interest, which you've done by some patient engagement practices, and we can talk about what that actually looks like in practice and how you can conduct that patient engagement. You've then come up with a couple different outcome options. So maybe walking capacity looks like steps per day, or duration of walking bouts per day, or frequency of walking bouts per week. And so the outcome to be measured is that more specific element of the concept of interest that you can practically collect with your connected sensor technology. So I like to think of the outcome as having like units or a time domain associated with it, because this is what you're clearly capturing with your connected sensor. And even if you've engaged with patients to get the meaningful aspect of health, you've engaged with them on how to get the concept of interest, you need to come back to them at this point too and check, like, does this outcome make sense to you? Is this outcome related to the concept that you told us prior? Because that's how you know you're going to get a signal there that will directly impact that patient's lived experience with their condition. The next slide is if you're in clinical research, developing a clinical trial, you're going to want to develop an endpoint. And the endpoint is how much change do you want to see in that symptom to develop a meaningful difference. So this is where you get into some statistics, the percentage change that you'll develop as part of that endpoint. And that might look different in each patient population. That might have the same measure, but what you're going to collect as your endpoint might look different depending on what those patient groups tell you. And then the next slide is pulled from the Playbook. So the Playbook is something that was released in September. It was developed by Dime, Electra, Genentech, Scripps, and a couple other groups. And this Measures That Matter paper is heavily cited in that Playbook to give people a framework of how you move through meaningful aspect of health, concept of interest to outcome. So these examples are really powerful. If you hear from a patient with anxiety, I'm exhausted and having trouble resting and relaxing. That might give you a signal, okay, sleep, that's something we can measure. And then what does sleep look like to this patient group? Maybe it's time to sleep onset is what you decide as your outcome, and then making sure that that outcome tracks back to what that patient told you as the meaningful aspect of health. And then the next slide is some references that we use to close the paper. And these are some places to go for further case examples and some strategies of how to do patient engagement successfully. And I think with that, we can open it up for discussion about, what does patient engagement look like in practice? I think that's the next slide, Jen, is just to broaden this back up. What does this look like in practice?
And some questions coming in already. Quentin, can I unmute you? Would you like to ask this question to Bray and Christine directly? You should be able to unmute at your end if you can.
I think it's done.
Yeah. Done. We've got you.
Yeah. Perfect. So thanks a lot. I found this extremely interesting and well presented. I've got a question related to when you were mentioning that we need the critical patient input when we look at the outcome is do these measures make sense to you? And I'm a bit confused because basically, if I look at an example, I know where in the working capacity, the turning speed is really key to demonstrate the working capacity. I cannot see myself asking to patient, is turning speed meaningful to them or does it make sense to you? Because they may not relate to this while they know that working capacity as a concept of interest is key. I feel that expecting that patient will tell me, okay, it makes sense, may reduce unexpected correlations or the fact that there is this particular element that may be complex for patients, but that is highly representative or highly correlated with some concept of interest.
I think Bray would have some great thoughts on this.
Well, I think this is where some of the models that we have referenced, they put all of the stakeholders in the room. And so I think having the multi-stakeholder conversations and explaining, this approach and then really the translation of it. And we got through an entire presentation without hating on the 6-minute walk test. And I think that's like such a great example of something where, maybe that measure clinically makes sense, but if you really talk to patients about the translation, is it measuring something meaningful to them? They would say it isn't. And so these are tough conversations to have, but I think you need to be able to translate that and help the patient population really understand why, why you're taking that approach to measurement and how, and then, work with them to say how it actually translates to their real life and what they actually care about.
It's helping to have an engagement from patients, or it's helping to be sure that what you're monitoring is relevant? This I'm not completely sure to understand.
Quentin, I'm really glad you brought this up because I think this is really important and it gets to the questions to ask at every level. And, Bray, what I really liked about your response is this idea that it's about a conversation and ongoing communication rather than those snapshots. And so in the example, and Quentin, it's a terrific example, so maybe let's dive into it a little bit, of turning speed. If let's say we wanted to then put patients out in the world, we wanted to burden them with using a technology, with charging it every night, with occasionally getting a text message to tell them that they forgot to charge it and to bug them to do it. If they can't see the value in something like turning speed, we know there's enough data that's come in that they are going to be a less sort of compliant group, which I respect, right? If they don't see value in that. So I think part of the finding might be, even if the answer is no, this doesn't make sense to me, I actually think you're taking a really sophisticated look at it. That may not mean sort of to throw the baby out with the bathwater, but it might actually flag something that you need to do in subsequent protocol development, in the training process to communicate why it's relevant.
Yeah, sure. I think it's in terms of engagement, I really see the points.
Have you conducted a trial with the turning speed in it, even if it's at the sort of feasibility level?
No, we were discussing on this particular item recently, and I mean, it was maybe not so well done in terms of patient engagement because we were really considering, okay, we just give patients the tools to measure this, and we'll do the calculation on our side once we tell them, okay, we are monitoring something. So this is where I'm trying to understand how we can do this in terms of engagement in trials, to say we are going to measure this particular item. Does it make sense? So I'm considering how we should do this also practically in a trial.
Mm-hmm.
Fantastic.
Whether it's in the protocol, whether it's in the consent form, how do we do this? Whether it's upfront when discussing with patients, I'm not completely sure how we do this in real life.
So I would say, I mean, first of all, you need to be doing it earlier. By the time you're selecting endpoints and outcomes and any type of measurement, if you've already designed that protocol without patients, you're a little late. So I would say, let's try to front end that engagement as you're actually developing, the design.
Fantastic.
Sure.
And this is, Quentin, it was a great case example, so thanks for bringing it up. And actually, it's a lovely segue to a question from Rachel. And Rachel, let me unmute you from our side, and you should be able to unmute yourself and pose your question live to Bray and Christine. And this is certainly something I've heard a few examples of recently.
Mm-hmm.
Awesome. Can you hear me?
Yeah.
Awesome. Thanks, Bray and Christine, for the fantastic presentation, and also to Jen for all of you working so hard for this fantastic and necessary publication. So first and foremost, thank you. My question is, so I think a lot of people understand broadly, which I hope they understand broadly, the importance of patient engagement. But whenever it comes down to actually doing the work, it gets a little gritty. So my question is, whenever I will often hear pushback like this, and I'd like to know how you all would respond. So what's the value in only getting feedback from just a couple of patients? How do we know that that kind of feedback is representative of many patients and not just what a few patients think? And I think I can distill that more by saying, how do you determine how many patients is, quote, enough?
Yep. I'll take that one. So I would call, depending on who the patient voice is. So if it's an individual patient, you're absolutely right. Just a couple of those folks, that's what I call a better than zero. And again, it's better than zero. So I encourage you to do it if that's your capacity. But the other thing is, if you're engaging with somebody who leads a patient group, then they should actually be, having their finger on the pulse of their patient population to understand subgroups and perspectives and know, what are the most burdensome symptoms, what are the outcomes of most meaningful interest to them. And so you have somebody who can then, provide a broader perspective. If you're going with the individual, then I think you need to think across, all the aims of diversity, whether that be, race, ethnicity, age, gender, geography, socioeconomic status, any type of disease experience. And then it may be that you have to do a mixed methods project that starts with some type of, survey and then moves into more qualitative work that oftentimes then interviews to saturation. But I think there are some trade-offs on, did you start this early enough to actually do that kind of foundational work? Or, did somebody just come to you and they're, designing their phase 2 or moving into a phase 3, and they're trying to decide, if they're going to add a different endpoint or a complementary measure. And then I think, you do the best that you can. And certainly we know that there are a lot of patient thought leaders that can speak very articulately and often have already generated evidence on what's most important to their patient community from things like patient-focused drug development meetings or voice of the patient type of research activities.
One of the things that stuck out to me, Bray, when we were, writing this paper is that you made the great point that it's more than just one focus group. We should be so much better and have so much higher standards beyond just doing one focus group at one point in time.
I appreciate that feedback. I think Bray saying that, well, it's better than zero, it says a lot about where we are as, an industry or anyone doing research. That should not be our baseline. I think we would all agree about that. So better than zero is better than zero, but we should do better than that. So thank you for that feedback. Really useful for me. I appreciate it.
Thanks, Rachel. And I wonder if I can riff off that a bit, because something else, and Christine, you jogged my memory about some of the discussions we had while this was under construction, was how can we think about using the digital tools themselves to actually help get feedback and input. And I wonder, Bray, I think you have some experience with that.
Yeah, so at Evidation, I mean, we have a community of 4 million members participating, and so it's a connected population, and what a terrific opportunity to ask in real time, or to design into your research, where you're gathering this information over time. And so you've got patient-reported outcomes, you've got surveys, whether they're annual or more frequent. But I think you can design that, and certainly let's take advantage of the connections that we have, because our members are in 9 out of 10 zip codes in the US. And so if you put together a focus group, you'd be really hard pressed to have that type of diversity.
I like the analogy that, in the same way that these digital technologies, we go back to the iceberg slide, right? Don't sort of restrict us any longer to those snapshots of data. The same thing should be applied to sort of the way we engage patients. And I'm sort of teasing out some threads. Quentin, I'm continuing to sort of chew on your really good question, because I think it's an important one, and one that folks might sort of bump into often, which is we have some clinical data that shows that this is a strong signal. But there's a bit of a disconnect in terms of its sort of perception through the patient's eyes. And then sort of adding that to sort of Bray, your comments that, to do this really well and really thoughtfully, it actually takes a decent amount of work and a decent amount of time. How do we make the case, right? For anyone trying to make the case internally to take a little bit of extra time, where we know that like timelines are like absolutely the thing that is crunched more than anything, to allocate a little bit of budget, to cede some control even around what's selected from the study team themselves to others. Like, how do we articulate that sort of value prop?
So there's already an economic model on return of investment for patient engagement that was created by a team from a multi-stakeholder membership team from Clinical Trials Transformation Initiative. And it was published in Therapeutic Innovation Regulatory Science Journal 2018, one of the more downloaded publications that year. And I would encourage everybody to look at that. And basically it was based on improved participant experience and elimination of protocol amendments. And so if you have to amend a protocol, we looked at thousands of phase 3 trials, and it could take, delay your timeline 8 weeks, cost $500,000. And then also, cycle time metrics, we know that there are benefits for being first to market, and those can actually, translate through to tens of millions of dollars, if not more. And this is an actual, it's based on real data and real numbers. And I'm not the health economist, but if you've got people, so you've introduced this measure, into this trial, and you've got people who aren't compliant for the reasons that Jen, mentioned earlier, where I just don't get it. It's burdensome. It's hard to do, and I honestly don't understand the value to me. There's a good chance you're going to have some low quality data, and so maybe you'll have to amend the protocol, or maybe that's going to tank your trial or whatever evidence generation you're doing. So I think there certainly is a model for this, and then the improved participant experience. Obviously, if patients believe that it's a good thing and they feel more satisfied, this is all good for our projects.
Yeah. What's coming to mind for me is that slide in the playbook, Jen, where we show some of the pain points of when you select technology first, or you try to do ops first before you do your measures. I'd almost say like patient engagement should be like somewhere included in that flow, right? So that people, understand how important this is to the overall success of the trial, as Bray just described.
Even in the Duchenne field, I feel like they've moved, so rapidly. I mean, to them, I'm sure it doesn't feel rapid, but they've really been leaders in the field. If you haven't got the buy-in, and then you want to put some type of giant sensor on a kid's leg and then ask them, to make sure the parents are making sure the kid wears this and charging it, but yet you're generating something that might be a measure that doesn't matter to patients, like, we're in trouble. So take the opportunity to work with the patient community up front.
Agreed.
And something else. Oh, in fact, great question coming from John. John, I'm going to, you should be able to unmute yourself and ask live if you're somewhere you can talk, John. And I'll give it 1 second. You're still on mute, I think, from your side. And oh, you can't. Yeah, no problem. So let me pose this to Bray and Christine. So based on what you've seen so far, what are the most essential components in building and maintaining trust among patients and patient advocacy organizations? And what are the biggest barriers? It's a great question.
Awesome question.
I'm big on the early engagement piece. I think it's really annoying from the patient and patient advocacy organization perspective to be like, hey, we already did this. Do you want a box check for us? And just not being, you know, like a true valued partner who actually has influence. And when you make the effort to have patient input, you should see kind of the action reaction, the change, and that feedback should be incorporated. And so I think those are, you know, some of the bigger challenges.
What's coming to mind for me, at least, is an example that we put in the paper where we talk about biomarkers a little bit. And so let's say that, you know, the traditional measurement that you're using is reduction in tumor size. And at the end of the oncology trial, the tumor size has been reduced to that, you know, whatever you decide as the endpoint, but the patient still can't sleep, or, you know, just feels really fatigued, like generally just feels like crap. And you tell them, well, your tumor was reduced. They're going to say, you know, so what? I still feel terrible. So I think that is one of the boundaries and barriers is, you know, developing what's gonna, you know, the tumor size is still important clinically, but can we do better than that? Can we, you know, drive meaningful change for that patient?
Christine, I love the nuance you just teased out, which is, but can we do better than that, right? I think we'd be hard pressed to talk to an oncologist who wouldn't tell you that tumor size reduction is a good thing.
Mm-hmm.
But like, what else can we do? And I think about that becoming a new sort of baseline in our mentality to these things. And I think about sort of where we are in our sort of subfield of digital clinical measures and the opportunity we have here. You know, sometimes I get frustrated because I think these measures are held to a higher standard than traditional measures. And I don't think that should hold us up in the immediate term, but ultimately I do see them as having more promise, more ability to actually do more for patients and more clinicians who want good information. And Bray, I was rabbiting along and I think you were going to say something as well.
Well, you know, I would just say, I mean, I think Christine's example is a good one. That is a very real example. And so let's say the chemo drug people can't sleep or their joints hurt. A lot of times people are frustrated with, you know, cog fog, but that's harder to measure. So maybe sleep is what we can do now. Maybe pain, maybe functional mobility, some things are useful, but I think there's a real opportunity if you've actually have that dialogue and the patient community said, this is important to us, but you're not in a place where you can measure it yet, then you can come together as a field and work hand in glove over time to find a way to measure cog fog in the future.
Yeah, I like that sort of aspirational stance. I have another question actually that came out of a conversation based on our webinar yesterday, actually. So we were referencing DIME's library of digital endpoints. So for folks who don't know, we maintain on our website an open source sort of repository of all of the digital endpoints that we know that are being used in industry-sponsored trials of new medical products. We launched that almost a year ago in November, and I think we launched it with something like 37 digital endpoints. We thought this was fantastic. There were 18 organizations using them. We had 37 measures, and there's an update that will get shipped today that puts us at 150 unique digital endpoints, and I think 57 sponsors. So huge growth. And someone reacted to this yesterday, and it was during a one-on-one conversation. They said, and one day we'll have thousands. And I thought to myself, I'm not sure we want thousands. I'm not sure that's a good thing. One of the goals sort of with the library is to try and show areas of activity and maybe, you know, not only show that this is being adopted, but to try and concentrate efforts and have efforts supporting one another rather than sort of small snapshots of data and individual trials. How do we think about, and going back to some of the questions from earlier around sort of what's the value in doing this, if a pharma company sort of does the hard work and actually builds this into their timeline, I could imagine not wanting to share any of that information. That's up to them. That's a differentiator. I'm also conscious that we often burden patient groups with the expectation that they do all of the work for us. So how do we get this right? Who's responsible and how do we share the learnings?
So some spaces there aren't a patient group, but I do think that where you have a well-organized patient group, people have taken the time to develop, research, strategic plans and things, to really do the work that's necessary to understand what's most important to patients. And off the first part of your comment and thought, Jen, we have to be fit for purpose. So there might be 1,000 measures, but what is the right measure for whatever this trial or product or opportunity is? It's scary to me as a patient because I do see once something is successfully incorporated into a regulatory trial or registration trial, and particularly one that's successful, those measures get proliferated. And we have to be, I think, really careful. And I don't think you can skip the patient engagement step of checking in and making sure that this is a meaningful measure in this application.
I really like that. And I think back to sort of the iceberg slide again, and you just sort of imagine, what if everything that's sort of below that horizontal line, everything that we can capture now digitally that we haven't captured before, what if it's all noise? And I think that sometimes people, even if they don't put it into practice, sort of get the benefits of doing this. I'm not sure, and I was really glad that you started with that slide, I'm not sure that there's yet sort of full grasp on the risks here, on the risks of actually layering in inefficiencies, layering in new subpar measures, measuring more things that don't matter to patients, and how, as you said, Bray, sort of that could immediately sort of impact the field.
I don't want to entrench a new 6-minute walk test. Like there are apps out there, right, that allow a patient to do a 6-minute walk test at home. But is that the thing that we want to be pushing towards? I think you could argue probably not, based on some of the things we've talked about here today.
Yep.
And what's, if we go a little bit beyond what's sort of covered in the paper, we've talked a lot about identifying the measure, and that's the focus of this framework. That's the focus of this paper. But then we can also think about some other considerations, sort of how do we think about the relative importance of sort of patient engagement through things like technology selection, through this sort of operational considerations, either to use this in clinical practice or in a research design. Can this information be captured together? What are your thoughts on that?
I mean, I think that the utility and usability metrics is an area that is understudied and underpublished on. And I think that those types of questions are worth a dedicated research effort to do satisfaction surveys or other metrics. I'm sure, Bray, you have some awesome examples of, actually ways to collect this data. But I think those are worth doing full studies on and publishing and like building a body of evidence that this form factor is really terrible for a given patient population. And let's not, develop a tech in that form factor for XYZ. Yeah, I think we need to do more research in that area, I'd say for sure.
Yeah, and I'll just pick up on that where I still think mostly I see there's a technology, there's a thing, and the thing is looking for, something that it can measure in some way, to market and to be incorporated. But I hope from this framework and from, VIV3 and other things, it's clear that we should always start with measuring what's most important to patients, and then let's figure out how we do that in the best manner and with the best technology.
Mm-hmm.
And I have one more. I'm totally sort of loading a question here. And in fact, Quentin, I see that you have, I've talked a lot. Let me unmute you again. You should be able to unmute yourself and ask your question directly.
Yeah, I think you can hear me now. I just wanted to comment on the point that you were mentioning, that we need to be sure that patients will be happy to use the different solutions that we have. And I'm coming from a field, so I'm working for EMD Serono. I'm coming from a field where we develop devices for marketed products, so without any incentive for patients to use the solution. And it feels to me like in clinical trials, there is this assumption that because there is a protocol, there is a study, there is a reason for patients to use the device, we accept that there is a burden for them and that they will accept the burden. And in fact, because we accept this, it does not work. We don't put first the notion that we have to do something that is satisfying to use for patients. And I don't know if it's where it's coming from, but it's pretty clear that there is a lot of work that can be done there, and the tools exist. The tools that for good usability or human factors assessments of solutions, they exist and they can just be applied.
Well, I think all of this is based on return of value, and I don't care if it's in a clinical trial or some type of complementary tool that supports, use of a product. You have to think of what's the return of value to patients, because even if it's in a trial, they're not going to use it. And I think we still, take too much data. What are patients getting back in exchange if I'm going to use a device every day, or if it's say a diary capture, or if it's passive, continuous, and objective. What do I get out of that? And it's not any fun if I can't ever see the data or use it, or find that it's measuring something meaningful. So
well,
I would.
Yeah, sorry, go ahead.
Sorry, just focus on return of value in all aspects, I would say.
Yeah, that's why I think the paper you cited before from the CTTI on the return on investment is really key. I think it's really putting the important aspect there in front. Say, okay, you've got a trial, you're going to evaluate the NPV of a trial. And so if you don't have patient engagement, you don't have good values. That's it.
Yep.
Good.
And Bray, we cite the city framework in the manuscript, I think, and you also included it in the slides today.
I don't think I put the economic model in. I think it linked to the general project. So if I can, I'll try to multitask and maybe put it into the chat. Does that work? Okay.
Let's also add that when we upload the slide deck, we can add an additional link before we do that. So Quentin, I'm really glad you flagged that as being important. We can add that to sort of the body of resources here. So thank you. A really lovely comment from David. I know he isn't somewhere he can talk right now, but David, I will give that voice in a second. In the meantime, Bernadette, if you'd like to, you can unmute yourself and ask your question live. Oh, you'll have to unmute yourself from your end. And if you're... Okay, perfect. I don't want to put anyone on the spot, so I'll give voice to your question. So question from Bernadette here, Bray and Christine. How do we get patients who are not organized in groups and are not educated enough on disease, but rely on care experts to sort of participate? And how do we sort of get their voice heard in this process?
Okay, I was multitasking, but I think if I'm interpreting this correctly, so any patient who's experiencing a disease or condition, you're a KOL, you're an expert in what you know. And I think sometimes it's useful to have kind of that interpreter translator who can help elicit or structure the patient input. But I don't feel like there's been all this push to have patients be trained and become research advocates. And I think that's like a super specific role. And patients just, by waking up and living with their condition every day, have valuable insights to share.
I would add in the care space, I think we got asked like a similar question in one of the Playbook masterclasses. I think in clinical research, you have opportunities to measure more things. And in clinical care, you might feel more limited to what you can actually like reimburse for and like get paid to assess and measure. So I don't know if there are like potential pain points there of, how to reimburse your time as a physician and like what you can measure. And Bray, if you have thoughts on that, I'm sure be great.
Yeah, I mean, even so remote monitoring, so now that we're starting to see some reimbursement for that, is it actually enough? If you want to scale that, does it support staff time for getting people connected to whatever device and providing the right level of support to make that, make that valuable and successful? And so I think we have a lot of struggle there. I mean, I hope that, I see some health systems making a little slow progress and engaging in that area. And then I think some professional societies, but a lot of times when I go to professional society meeting in my disease space, I'm often the only voice. And, that's not really enough. So I think we just have to have more systemic engagement to ensure that we're providing value and then creating, the right reimbursement models or value-based frameworks.
Yeah, I would agree.
Fantastic. And I think that's exactly right. One of the things we actually recommend in the playbook is around this model of tiered training. So recognizing if there's a need to do sort of additional training to really make different types of patients, maybe sort of less digitally sophisticated, for example, more comfortable. And, you know, if we look at I think there's a lot more in the current sort of physician fee schedule that are being proposed. I think currently there are sort of 6 ways you can charge, and around device training does exist, but I think it's limited to something like 20 minutes of first setup. And there will definitely be patients who require more than that. So it's
yeah, but the data, it didn't sync, the data didn't upload, you know, I mean, come on. So it's a start. I mean, just think about where we were a few years ago. So it is a start, but we still have a lot of work to do.
John, I know that you're not somewhere where you can chat right now, so I'll give voice to your really sort of thoughtful comment here. As you say, not a question, but a comment, and Bray and Christine, you may react to this. So when John surveyed their members at Inspire or using Inspire about why they would or wouldn't participate in clinical research, the top reason for participation has been that it would lead directly to benefit for them. And the other was that their contributions would help others, and every other motivator was really low. So we sense that they desperately want that feedback, Bray, like you said, that hits more clearly, more transparently on one or both of those motivating factors. John, that's great, great data there. Thank you for sharing. Bray and Christine, any reactions to that?
That's awesome.
Yeah, I mean, I think at a minimum, so returning value, depending on the technology and depending on the setting, depending on the trial, there are a variety of things you can return to patients that create value. At the very minimum, you can return study insights. You know, X number of people participated in this. Thanks, you were included in this data set. You can also return summary results. And sometimes that's not super satisfying because it might be, you know, a time lag that doesn't really drive engagement. But again, I think return everything that you can that creates value. You can also send periodic, periodic aggregate review. And then there's a 150-page document for those of you that have insomnia that we created on return of individual research results from the National Academies of Medicine. And there's a lot that we can do. And I think, again, we have in this emerging field of digital health technology tools and the data that's being captured, we need to think about what are the useful insights, and then also, the difference in research insights versus clinical insights.
Yeah, I agree that information like that of what would motivate a patient to sign up for a trial should, I think, be shared with a lot of PIs out there who are developing trials. I mean, I can think back to ones that I was a part of as a clinical researcher, and I had patients who I was enrolling say, when will I know if this gets published on? And my answer was, we won't tell you, but you might see a publication pop up on our website, which is a really frustrating answer to get.
Yeah. So. Yeah. So there's a push-pull. I mean, and definitely I encourage people to plan proactively, and you should have a return of results or return of value plan as you're, planning whatever the project is. And you should also budget for it. These things don't happen for free. And we just, we know there's a reality that people need to get paid for their time. And so make sure you budget.
Yeah. Good point.
So a couple of really good comments here from David. I know that you're not somewhere where you can talk, but I'll throw these on the table, and Christine and Bray, see if you have any reactions to these. So the first is some of the limited sort of reimbursement codes for sort of use of remote patient monitoring. And this is a great point, David, because you're exactly right. David's a PT member of DIME. And, our physical therapists spend a lot more time and develop a much closer relationship with patients. David, I'm totally embellishing your comment here, but hopefully you don't mind if I add some color. Spend a lot more time with participants. So, really thinking about what we can do to give voice to getting them sort of reimbursed for that work, and recognizing that that's important. And then another one, David, that you typed into the Q&A here, really sort of underscoring sort of some of the ways that you're thinking about using this in stroke patients, for example. That's a really terrific example, and +1 for needing to replace the 6-minute walk test. I also think that, you know, the most important sort of stakeholders to talk to are obviously the patients, for all of the reasons we cite in the paper and that we've discussed today. But I think some of your comments here, David, and even sort of some of your reflections, sort of Quentin, is that, you know, there are a lot of sort of stakeholders who are involved in how we use this information. So I remember doing some work at the Clinical Trials Transformation Initiative on a use case in Parkinson's. And actually some of the most thoughtful feedback came from some of the movement specialists and OTs and PTs who actually work really closely, and their voice sort of really amplified what the patients had to say. And it was sort of important to go to everyone who sort of had a seat at the table. Bray, Christine, I'm not sure if you have sort of any thoughts on that.
You know, the only relevant thought that I have, and so I've known David for years, just so you guys know, he was the vice president of the organization that we founded together.
Nice.
Yeah, years ago, that worked with stroke patients, and just, you know, there's actually been you know, published peer-reviewed studies that show that when you do, you know, remote PT or you know, deploy digital tools, there's an improvement in outcomes. And so I think maybe it's just an implementation, you know, where we just have to keep populating the literature and keep pushing on, and having, you know, a professional society or a group that's willing to lead the charge, I think is a big thing for the groups that have been more successful in getting reimbursement. And it's hard, David, because I know you have been on the front lines and trying for years and years, and you only have so much energy. And, you know, as an individual, you can only do so much. So hopefully somebody on this call can help with this.
Fantastic. Yes, I saw a note come in there. That's terrific. Everyone, this was a terrific conversation. Bray and Christine, congratulations on such a terrific paper. I also, you know, these are hard conversations. I think we're all under pressure to make forward progress. And, you know, I think there is a misconception that this feels like slowing things down. But what sort of was clear from the manuscript, what's clear from some of the resources you cited, Bray, in the conversation today, that this is an incredibly, incredibly important investment of time, not just for sort of the patients we serve, but for the success and the impact of the field, right? If we think about actually being intentional and not creating digital noise, but actually really sort of steering this sort of ship of digital measurement towards sort of the focus on the North Star, which is our patients. So let me do just a couple of things before I close out, and thank you. I want to highlight a couple of upcoming discussions in case it piques folks' interest. Our next journal club is on November 10th, and we'll be looking at some of the publications that have come out of some of the IMI studies on gait speed. So that's up on Conversation next month, and I hope many of you can join us. We also cited a couple of slides from the Playbook today, and our next Playbook masterclass actually dives in on specific considerations for remote monitoring in clinical care. I am absolutely confident that some of these questions around technology training, around reimbursement will come up. So if that is important to you, if that is something you are grappling with, certainly please do join us. And with that, I will close out. Thank you everyone for joining us today for a great discussion. Bray and Christine, terrific remarks today, really, really terrific conversation. And we will post the slides, and Quentin, really great questions around ROI. We'll add that link to the slides before we post them. So if anyone's looking for that, we will get it up on the website. So with that, I hope everyone has a wonderful day, and thanks so much.
Thanks, Jen. Thanks, everyone.
Bye-bye.